Yeah, thank you, Jeffrey, and thank you very much for giving me the opportunity to talk about this important topic here. I'm a professor of clinical immunology, and actually I have been in charge of post-infectious syndromes already many years prior to the pandemic. May I have my slide presentation shown, please? Oh, okay, thank you. So you go this way. Yeah.
No.
Okay, I'll turn. So I'm going to talk about the dimension and spectrum of long COVID, and then on pathomechanisms of long or post-COVID syndrome, as it's called too, and myalgic encephalomyelitis, CFS, which is a subtype of long COVID, and then about management and care. My disclosures are shown on this slide too. And long COVID is actually not a new disease, but similar post-infectious syndromes have been known for many decades, including post-Lyme or post-EBV or post-Dengue fatigue syndrome. What is, however, new is the dimension of a pandemic of long COVID now. And we have many epidemiological studies now, and this is the most comprehensive summary of all data which is available so far from the US Institute of Health Metrics and Statistics, recently published. And based on this, we estimate that we have a global cumulative incidence now on about 5% of the global population, which are 400 million sufferers of long COVID. And this, of course, has a major impact, not only on the health system, but also on society and economics. And there are also some studies on the effects on the global gross domestic product, which shows declines of up to 2% in 2024 due to long COVID. There is less data on the prevalence of long COVID in low-income countries. That's a study summarizing data from Africa. And looking at this data, it looks as if the prevalence of long COVID is much higher in many African countries, which may be at least in part explained by the lack of vaccine protection in many of these people, because we know that vaccination is protective for long COVID. So we have little information in low-income countries about prevalence, about potential additional risk factors, and we have often a lack of care structures, and there are even physicians acknowledging that long COVID does exist. That is probably not that much different from other countries worldwide. And what is quite worrisome, that we have now several studies clearly showing that the risk of long COVID increases with every infection. For example, here this study shows that the risk of long COVID almost doubles with every consecutive infection, and that is now true for the Omicron period. So long COVID is definitely not over. And what is important too, that's what I want to stress, is that it's not only COVID triggering such post-infectious syndrome, but this is one study being representative of several other studies too, showing that we now in the year 2024 have a comparable risk of developing post-infectious syndrome triggered by other viral infections. That's shown in the middle figure, the blue columns on the bottom, and the figure on the right is showing the risk of developing comparable symptoms independent of infection. So clearly giving proof that both COVID but also other infections can trigger these post-infectious symptoms. So what is long COVID? What we all know is that we face numerous symptoms in those who develop persisting symptoms with fatigue among the most prevalent, exertional intolerance, shortness of breath, neurological symptoms, and many more. Our problem is that we still do not have good diagnostic criteria, and we still do have little understanding on the different types of long COVID and subsets. And this is also complicated by the facts that we now work with various definitions. So we have more than 6 definitions now. The most frequently used is the WHO definition. So everybody who has persistent symptoms for more than 2 months, occurring within 3 months of infection and impairing daily activity, is defined as suffering from long COVID. We do have definitions in which also new diagnoses like heart infarction, like thrombosis, which develop as a sequela of COVID are included, or patients who develop organ dysfunction following intensive care treatment, and other definitions just focusing on the post-infectious syndromes, which is probably the definition which is more relevant, because this is a major subgroup of patients. Approximately 90% of patients suffer from these syndromes, which are still poorly defined yet. What we know is that a subset of patients develops a disease which has been known already pre-pandemic, and which is a disease which actually has been around for at least a century, and it's called myalgic encephalomyelitis, or chronic fatigue syndrome. And this is a really debilitating and chronic disease, which can be triggered by various infections. EBV is a well-known trigger, but also influenza or enterovirus. And now SARS-CoV-2 is the most frequent trigger. And this disease is characteristic, is the severe exertional intolerance, meaning that often minor daily activity, just daily care, can lead to an aggravation and worsening of all symptoms. And symptoms include the fatigue, but also neurocognitive impairment called brain fog. Patients typically suffer from severe pain, sleep disturbance, orthostatic problems, and many more. And we have initiated a study in summer 22 to learn if SARS-CoV-2 triggers ME/CFS, and if this is comparable to ME/CFS we know from other infections. And what we learned in our study and from other studies is that an estimated 10 to 30% of long COVID cases do suffer from ME/CFS. It's classified as a neurological disease by WHO. There are data from the US, from the CDC, that it's estimated 1.2% of the population suffers from ME/CFS, so it's really a frequent disease. And it's a severe disease. At least 50% are unable to work, and approximately 25% are severely impaired. It's a disease of predominantly female, middle-aged females, but also can occur in children. And the problem is we have no specific treatment so far. So it's a chronic disease. And we do not have adequate care structures worldwide for these patients. And on the right side, you see a figure from our paper showing that also in those developing ME/CFS following COVID, the majority has a chronic course with no symptom improvement over the consecutive 2 years. So as I said, we have a subset who are severely ill, bed-bound, and are a major healthcare and social problem. So coming to the pathomechanisms, what do we know? What causes long COVID or post-COVID syndrome and ME/CFS? That is a complex topic again. So until now, we have numerous studies analyzing in depth and with omic technologies patients. And what we've learned from these is that there are actually several mechanisms ongoing, and we have no clear, complete picture how they all belong together, or if we do face subgroups of mechanisms at the moment. What is known for sure is that we have a severe immune dysregulation in many patients, which may result also in inflammation of the brain, inflammation of vessels, and consecutive mitochondrial dysfunction. And there's also some evidence that viral persistence occurs, at least in a subset of people following COVID. Regarding immune dysregulation, I think we have the best data and the clearest data at the moment that this is a cause, at least for a subgroup of long COVID and also ME/CFS sufferers. This figure has summarized the data from numerous studies we do have on autoantibodies which are triggered by SARS-CoV-2. EBV seems to play a role also, because EBV reactivation during COVID is a risk factor to develop long COVID. And we do have autoantibodies against neural structures, but also muscles and other targets. And I think the most convincing data is from the group of Akiko Iwasaki, who showed in this beautiful model that transferring IgG from patients with long COVID into mice could induce very similar symptoms that's shown on the left side for a pain test, and on the right side for a fatigue measure, showing that the mice do have a diminished muscle strength after being treated with these IgG from patients. And a similar study was published from a group in Amsterdam. So coming to management and care during the last minutes, this is a picture taken for the German Reichstag, a demonstration of patients for adequate care structure. And I think that is again a problem which is very similar worldwide, that we have no adequate care structure at the moment for these many sufferers with long COVID. And the situation was very similar pre-pandemic for ME/CFS patients. So what makes it so difficult? First of all, the knowledge is still very limited. Then we have very little evidence on effective therapies from clinical studies. The drugs we can use, many of them are off-label, so they are not reimbursed and often not prescribed by physicians at all. As I said, diagnostic criteria are heterogeneous and not specific enough, so it's always a diagnosis of exclusion, which requires, of course, time and money. And then we have in Germany, and I think the situation again is not very different in most other countries, few specialists, and those have long waiting lists. In Germany, we now have guidelines from the Gemeinsame Bundesausschuss, which is suggesting how to take care of these patients. And actually, there's nothing new written in these guidelines. It says that patients should be taken care of as other patients with severe chronic disease by collaboration of the primary physicians, the specialists, special clinics, and home care structures. And the key elements of improving long COVID care is awareness, is education, is reimbursement, and is research, which I think is very true. So what possibilities do we have at the moment to help these patients, to treat them? So treatment is so far only symptomatic. As I said, many drugs are off-label, and we have no effective curative treatment so far. What we do have is a list of therapies which can help patients at least to improve symptoms. This is actually an overview of several papers, mostly in German, and we have published during the pandemic how to treat the most worrisome symptoms, the severe fatigue, exertional intolerance, sleep disturbance, pain, cognition, or aesthetic problems. They all can be treated by drugs which are available already. In Germany, we do have, at the German Government of Health, we do have a working group working on a list of which drugs are available already and are recommended for treatment. And we also study which drugs might be put on a list as off-label treatments to be reimbursed based on the available evidence on the studies we do have already, mostly have been performed in ME/CFS, most small studies. So I am concerned that we won't get many drugs on this list in the end. What we urgently need is the development of targeted, effective, and curative therapies. And based on the knowledge we do have on the pathomechanisms already, several drug treatments have been initiated worldwide, although the number of treatments initiated is much too low. And what is really disappointing is that pharmaceutical industry is still holding back and are not very much interested to develop drugs on this disease due to various reasons. One is that it's still not very well understood, and development of drugs is of course very expensive nowadays. We in Germany got funding from the government again, and we built at Charité our own clinical trial platform to perform clinical trials with already licensed drugs, because this is the fastest way of developing drugs using a drug repurposing. And we focus on the most understood mechanisms, autoantibodies, inflammation, and hypoperfusion. And we combine these treatment trials with comprehensive research because it is still known to understand which patients respond to which treatment and to identify biomarkers for the subgroup of patients responding to therapy. And in the last 3 minutes, I just want to show you first data we have, which gives us some hope that we are on the right path. One trial we do is on hyperbaric oxygen therapy. A similar approach is followed in Israel and at the Karolinska Institute. And this is actually a very interesting treatment, because the high oxygen concentration we can achieve by this chamber technique leads to an amelioration of inflammation, can induce new vessels, and can improve mitochondrial function, which is also severely impaired in many of these patients. And this is just an interim result. That's an observational study we perform in the most severely ill, the ME/CFS patients, just to wanted to start with this to see if this is possible at all to treat these patients. And there are data from Israel showing already in controlled trials that it's well effective in a subgroup, and it also has sustained efficacy. In our ME/CFS cohort, we see that many patients do improve as well, and this also can be made objective by showing that patients do have improved physical function after being treated for 8 weeks in this chamber. Another also observational study we started with is immunoabsorption. That's an apheresis technique by which we wash out all immunoglobulins in the patient's serum. And by doing this, this is an effective therapy for autoantibody-mediated diseases. So it's actually used for many different autoantibody-mediated diseases. And this is the fastest way to understand if autoantibodies found in these patients do have a role in the disease. And what we've learned from this study, and this is shown from a paper which is just impressed in Lancet Regional Health Europe, showing that actually all symptoms we analyzed did improve very rapidly after immunoabsorption. So the green column shows the period of immunoabsorption and the values before. The lower value for fatigue on the left upper graph is well improved, and pain is much less after treatment. And the same is true for the post-exertional malaise, which is the severe symptom aggravation after exertion in these patients, and also autonomic dysfunction is improved. So this is quite promising, and this is the basis for us now to do treatment trials with drugs to target autoantibody producing B cells, and numerous of these drugs are already licensed and are very effective, like CD20 or CD19 monoclonal antibodies. So yeah, and this is my last point I want to make. The prevention of COVID is important, is very important. The prevention of COVID is prevention of long COVID, so we also should put more effort into these studies, which drugs also may help to prevent long COVID when you have already COVID, and of course vaccination is effective to prevent long COVID. So taken together, it's a global health, social and economic challenge. I showed that the estimated incidence in 2024 is about 5%. I showed that we do not have adequate care structures, that the development of targeted therapies is urgently needed, and that the prevention of COVID should have a high priority also to prevent long COVID. Thank you.